Thank you very much, Monique, for the invitation. I would like to thank the committee to invite me to this conference, and it's a pleasure to speak about ultrasound imaging today. I am in place of Matthias Fink, who was not able to come here today, but I have a great honor to replace him. Okay, so today we'll speak about ultrasound imaging. I will begin with the basics, and I will go into my presentation to new development of the ultrasound and how the current echographic device works. I will show you all the possibilities that we can have with it, and I hope it will please you. So, a little bit of historical. Ultrasound imaging started at ESPCI in Paris in 1882, so a long time ago the school was founded, and one of the first great researchers in this school was Pierre Curie. And Pierre Curie developed the piezoelectricity theory, which is the basis of ultrasound imaging. Later, Paul Langevin, who was also a director of the school, developed the first sonar in Paris. And with its invention, he developed some, of course, a military device for the First World War on submarines. And after that, in 1960, the first ultrasound scanners arrived on the medical market. So it was not so long time ago, so 70 years ago. And once again, in the school, in 2009, we have developed the first software-based ultrafast ultrasound device, and the last part of my presentation will be focused on this device. So, if I need to define ultrasound, ultrasound is in this bandwidth, in this range and frequency between 20 kilohertz and 200 megahertz. Below you have sound and infrasound, and at the top you have hypersound. If you define this ultrasound, this is just an increase of the frequency of the waves that propagate. Now, in the current life, it is used around you in a military application with submarines or sonars or submarine acoustics, and also in your car. When you hear a beep, when you go back with your car, this is ultrasound that allows you to hear the sound. It is also used in the common life around you by animals, so by dolphins or mammalians, or bats around you by night. And here, we use ultrasound in the field of medical imaging, and I will try to explain you how we can do some image like this and how we can improve diagnosis by using these images. So the advantage of an ultrasound image is to be non-invasive and non-ionizing. It's real-time. You have fast information, because you have a lot of frames per second, so you have real-time feedback. You have a lot of information for a low-cost device, so it's very important when you want to develop medical device. There is many applications. The technique, the modality evolved a lot, and now it's more and more lightweight and wearable. This is rapidly scalable, and there is also some development for non-medical application like non-destructive testing, but today we will focus on medicals. And as you see, the market increased a lot with time. There is more and more need about ultrasound in medicine. Where ultrasound are used in clinics? Ultrasound is mainly used to look at the anatomy, the functionality of tissues, sometimes for diagnostic applications, and the main field where they are used is the obstetric, gynecology, cardiology, and the last part is radiology. If now I want to show you an ultrasound, what is an ultrasound? An ultrasound is a bulk wave. This is a wave that propagates with a change of volume, and the axis of propagation is in the axis of its polarization. So where you have this movement, where the volume is compressed and unpressed, you see the propagation of the shear wave, of the ultrasound wave, sorry. The geophysicists call that the P wave, because this is the first wave they listen when they use microphone to listen Earth. And the speed of this wave is linked to the density of materials. So here we suppose that we are in tissue, in biological tissues, so it's 1000 for us. And the bulk modulus here, and the speed of ultrasound is defined by this expression. What are the other characteristics of the ultrasound? The other characteristics are the wavelengths, of course, the length of the wave. Its frequency, its period, its speed, which is very important to characterize many things, and also the acoustic intensity, the power which power we send the ultrasound in the body. If I look also at the ultrasound in terms of mechanics, these ultrasound are driven by the bulk modulus, and the bulk modulus in terms of mechanics is very high. It's kind of gigapascal. So the soft tissues are more than 1 gigapascal, and the bone are 10 gigapascal. If I look at the shear modulus, it's much lower, and we'll speak about it later. And if I look at how the speed evolves with the material, it depends on the bulk modulus. And so you can see like this, like in the air, it's 300 meters per second, 1400 in the fat, a little bit higher in the liver, much higher in the muscle, and as the bone is very hard, the speed of the ultrasound wave is between 2000 and 4000 meters per second. So when we work on ultrasound and when we build an image, we assume almost a mean value of 1540 meters per second, and we use mainly this main value to build our images. So how can we generate ultrasound in the body? For that, we will use piezoelectric materials, and these materials has the capacity to transform electric energy into mechanical energy and to transform mechanical energy in electric energy. And typically, a quartz crystal is a piezoelectric material. How we'll use it? We will fix 2 electrodes on each part of the material, and when we will send a current inside by switching the polarization, we can compress the material or extend the material, and this will generate vibration in the tissue coupled to the piezoelectric material. And in the other way, when you will apply a stress on the material, it will generate a current, and this is what you will record in order to build your ultrasound signal. So we will use in this piezoelectric ceramics in transmit, will send an electrical signal, and like this, the material will oscillate, producing a sound vibration. And in the other way, when you will receive a sound vibration, it will produce an electrical signal that you will record and use to build your image. So if I do a simulation, I can show you how it works. Here I have a transducer, one transducer. I send an electrical pulse to the transducer. It oscillates and generates a shear wave, an ultrasound wave that propagates into the tissue. As the transducer is more like a point source, you have a diverging wave that propagates into the tissue. Now, if you have a scatter, you will have an echo that will come back to the transducer, and you will listen this echo and record this echo in order to have to find the position of the scatter into the medium. Now, if you want to build an image, you will use an array of transducers, and you will send a lot of electrical pulse to each transducer into the medium. Typically, we program a focusing law in order to focus ultrasound along one line and to have a maximum of energy in the middle of the parabolic law we have programmed. And after that, so yes, the ultrasound will be focused along this cone. And if I have a lot of scatters into this region, I will listen a lot of echoes. All these echoes are recorded, and if I apply a focusing algorithm, a summation algorithm in reception, we call that a beamforming algorithm. We can, like this, build the ultrasound signal coming from the central line of this focusing law, and by taking the Hilbert transform of this signal, we can reconstruct one line of our image. Now I can do that for a bunch of transducer on the side to listen echoes coming from the other line, and I do the same processing, and I have a second line, and I do this one time and one more, and like this I can reconstruct an image. And here I have an image of the brain into a baby through the fontanelle. Now I know how to build an image, but I will use different ultrasound depending on the organs I want to investigate. If I want to look at deep organs, I will use a low frequency, because at low frequency I have a lot of energy, and the ultrasound can go through the whole organs. Why? Because the attenuation increases with the square of the frequency, so higher is my frequency, less deeper will be my image. So depending on the organ I want to scan, I will adapt the frequency of my ultrasound to have the image I want. So if I want to investigate liver, I will use low frequency. If I want to maybe more superficial, I will use around 10 megahertz, like for the thyroid here. If I want to go higher, I will have a small resolution, a higher resolution, but the depth will be smaller, so I will investigate only small animals. And at last, if I go higher and higher, I have very high resolution, but the organs will be very thinner, so here it's an eye, and I can just look at the cornea or the iris. And if I go higher, I can go to anatomical structures, but not, well, anatomy. I can have this kind of images. So the idea here that you must learn is that if you increase the frequency, you will increase the spatial resolution, but you will lose your penetration depth. So at low frequency, you can go deeper, but with a poor resolution. At high frequency, you can have a high resolution, but very thin organs. So this is how we built an image in ultrasound and the basic physics law to build this image. How the ultrasound evolved since 1960, I said. The image has improved in quality a long time due to electronics, to improvement in sensors, and many things like this. The way to build the image is exactly the same since the 75. This is what I described you just now. So we build the image in the same way, but as electronics and many things evolve and are improved, the quality of the image is better and better. And when you do that, you have a frame rate of about 50 frames per second, so you have real-time effect. As you may know, when you watch a movie, a video, or cinema, it's 24 images per second. So with 24 images per second, we have a real-time effect. So here it's the double, so it's quite enough to have a real feedback. And typically, the spatial resolution is around 200 micrometer, depending on the probe you use, but the main modalities are with this resolution. And with this kind of images, now we can derive a little bit this approach in order to have new imaging mode on scanners. And the 4 main imaging modes that are defined on ultrasound scanners are B mode, so the way I just showed you to build an anatomical image. Doppler imaging, I will describe with you that now. It's how you can see the vascularization of tissue. Contrast imaging, but I will not speak about that today. I think you will have courses about that tomorrow. And elastography, a way to use ultrasound in order to quantify the stiffness of tissue. So if I go to the first one, Doppler. Doppler was an Austrian guy in the 19th century, and he discovered the Doppler effect. It's me. Oh, sorry. I just cut the sound. Okay. And it was beautifully described by Sheldon Cooper. I don't know if you look at the Big Bang Theory, but if you look at the first season, episode 6, he has a beautiful suite, and this is representing the Doppler effect. So the Doppler effect allows to determine the speed of a moving source by just listening the sound it produces. So the sound it produces is proportional to the frequency difference between the transmission of the sound and the receiver. So when you have a car in the street that goes to your ear, the frequency is become higher and higher, so you will hear j'ai un trou, un aigu, sorry. And when the car will go away, you will hear a louder sound because the frequency decreases with time. So here, when you do some small calculation, you can see that the frequency you will perceive at your ear will be depending on the frequency of the source that emits the sound, but time ratio of the celerity of the sound and the speed of the car here. So if the car getting closer, you will have this relation, and if the car goes away, you will have this relation. This is just a minus here and a plus here. So the change in frequency is just due to the speed of the source that produces the sound. So we can use that in the body in order to find the speed of materials that move into the body. And what kind of material moves into the body? The blood, of course. So the red blood cells that move into the vessels move with a certain speed. And when ultrasound that is transmitted here will impact the red blood cell, the ultrasound will come back because the red blood cell is a scatter. So the ultrasound will come back to the receiver with a change of frequency. And if you are able to quantify this change of frequency, you can retrieve the speed of the blood that travels into the vessels. So the equation is quite simple. It's here. So the change in frequency is just 2 times the principal frequency times the speed of the red blood cells. Now there is also different tips different cases that you must know before to go further. So if the array is perfectly perpendicular to the vessel, you will have a difference of 0, so you don't find any speed. If you have an angle which is smaller than 90 degrees, you will have a frequency change which is positive, and in the other way it will be negative. And classically, in ultrasound device, this is how we color-coded the signal. So when you have a red signal, you have a blood flow that goes to the probe, and when you have a blue signal, you have a blood flow that moves away from the probe. So this is not arteries, veins. Sometimes people say that, no, it's not arteries, veins, this is where the blood is going. So red is going to the top, blue is going down. So here it's an example, if it works. No, oh, sorry. Okay. So here you see blood velocity quantification. So when it's red, the blood is going up to the probe, and when it's blue, it's going down to the probe, and it's color-coded like that. After that, you can also have a relationship between the frequency change and the speed you estimate. And so you see here on the color-coded bar, you have between 51 centimeter per second and minus 51 centimeter per second. Yes?
So that's in the case that you have a resolution that is superior in the dimension of the blood vessel.
Yeah.
For example, suppose that you want to know if the liver of somebody is well perfused. In that case, if I remember correctly, the resolution, since you look deep into tissue, will not be enough. So you will, in fact, you will get a distribution of velocities towards the probe, away from the probe, and so on.
Yeah.
And therefore distribution of different frequencies.
Yeah.
Some higher and some lower.
Yeah.
I suppose that you can reconstruct a perfusion also from this distribution.
We can do that, but not like I just show you here, because here we just listen at one point. But later in the presentation, you will see when we use plane waves, we can have a distribution of the wall speeds that propagate into vessels. And you can find the I will not show you that, but it's possible to find the Gaussian distribution of shear blood that propagate into vessels. It's not a problem, but I will show you that a little bit later. Yes?
It's a great question, and maybe to build on that, what if you have a patient with myocardial infarction where you have like a small occlusion of one of the coronary arteries?
Yeah.
Could you use that like, in the distal and proximal segments of the coronary arteries and measure the blood flow, like doing something?
I think you cannot use a classical Doppler. I just show you the classical Doppler. But what we call the ultra-sensitive Doppler or ultra-fast Doppler that I will show you later, I think it will be able to use that to look at coronaries. I will not speak about coronaries today, but I can show you on my computer later if you want. But with ultra-fast Doppler, I think it's possible to do it. Yeah? Yeah? Sorry for the movie, I'm sorry. You want to see the movie? No. Yeah? Yeah? We send ultrasound, we listen ultrasound, and we just look at the change of frequency of the ultrasound that comes back. So this is the same probe, and this is the same ultrasound. So in the first, to build an image, we just take the kind of Hilbert transform, the envelope of our signal, in order to build an anatomical image. And when you go further into the signal and you look at the change of frequency, you can go to the Doppler reconstruction. This is the same probe, the same ultrasound. We just analyze the signal in two different ways at the end. Mark? Yeah.
You mentioned that the blood cell is making the scattering, or can you image just the liquid flows? Or is it really the ultrasound is coming from the actual?
Echoes are coming from all the scatters of tissues. So in the blood, of course, the bigger scatters are the red blood cells, but if you have other things that can go send back echoes, you will listen that too. But if I can differentiate them, I don't know. I just know there is something that's moving at this speed in the vessel, that's all. I say red blood cell, of course, because it's easier to understand, but if you have microbubbles, you can do the same thing with microbubbles. Okay, so I showed you how to build this kind of images. I showed you how to have Doppler imaging in order to have an image of vascularization. But sometimes, if you use ultrasound, there is a lack of specificity. And you see that the image has evolved along years and the quality improved a lot, but this is not enough. So the sensibility increased a lot, but sometimes it's not enough in terms of specificity. An example to illustrate that is if I speak about, I'm sorry, I don't see very clearly here, but if I speak about breast cancer diagnosis, here you have three images. I'm sorry, you don't see clearly, but there is a black hole here, and you see the black hole here and here too. And this black hole is quite the same on the three images, but if you do a biopsy, it's quite different. The first one is a fibrous lesion, totally benign. The third one is a viscous cyst, so it's just some liquids. You can take it out without any problem with just a syringe. It's really easy. But the middle one is a cancer. It's very malignant and it's a problem. If you have just the gray image, it's very difficult if you are not an expert or eye radiologist. It's very difficult to distinguish them. So how can we improve the specificity in ultrasound? The first idea to try to improve it was to go back to the first medical action of the physician, the palpation. When you go to see the physician or the gynecologist, he will palpate you, he will palpate the liver to feel if it's hard or soft, he will palpate the breast to feel if it feels some nodules, some balls or something like that. Same on thyroid. And in terms of physics, the palpation is just the way to apply a stress and to feel a strain. You will just deform the material and it will generate a strain. In terms of physics, it has been defined by Jung a long time ago, and the stress over the strain defines the Jung's modulus, which is the elastic modulus of tissue. So the first idea, initiated by Jonathan Ophir in the 90s, was to try to translate this physical approach in an ultrasound device. So he said, oh, I can have an image before compression, I can have an image after compression, and if I do a calculation between both images, I can like this retrieve the displacement into the image before and after the compression. And if I take the derivative of that, I have the strain. So like this, I can have an image of the strain, and it was implemented into the device, and it gives you a new information that you can couple with your classical B-mode image in order to try to do a diagnosis. So here you have an example on a Siemens device or a Toshiba device, and it's color-coded, so when it's red, you have small strain. When it's blue, you have high strain. So you can say, oh, everything in red is hard, everything in blue is soft. But this is just relative, because you don't know the stress you have applied. You just quantify the strain. So with static elastography, you have only this parameter. You don't have this parameter, so you can have a quantification. You have a qualitative information, which is complementary to BMOD imaging, but it's not enough. So we propose to rewrite this equation in this way. This is a classical way defined by the mechanical theory. And the Young's modulus can be also expressed as a function of the compression modulus or the bulk modulus, so this is the same factor, and the shear modulus. So the compression modulus, the bulk modulus, is the way that have a medium to change its volume. You remember when you saw the ultrasound propagation, you see a change of volume that propagate in the direction of the polarization axis. And if and the second parameter is the shear modulus, so the way that has the medium to be sheared. In soft tissue, as I showed you some slides before, the bulk modulus is much higher than the shear modulus. So this expression can be resumed to 3 times the shear modulus. If I express also these 2 parameters in terms of waves, the bulk modulus is related to the speed of the sound or the ultrasound. It's related to the speed of compressional waves. So here in tissue is 1,500 meters per second in mean. And this is the same for the shear wave. You have a shear wave that propagates with a certain speed, which is really directly related to the shear modulus. And the shear wave propagates like this. There is a polarization which is perpendicular to the axis of propagation, like this. So you see here that if you are able to quantify the shear wave speed, you get the shear modulus, and you can go back to the Young's modulus. So by analyzing this wave, you have a quantification of stiffness, and you can be better than the static elastography approach. So, have you ever seen a shear wave? Somebody? No? You have seen a shear wave? Where?
Because I work with ultrasound string theory, so when the ultrasound is scattered by object, we have like compressional wave and shear wave.
Okay, so you're in the field. Okay. So here I can show you, this is a shear wave. So this is during the Gulf War. They detonate a bomb here. And what you can see here by the dust moving to the cameraman is a shear wave that propagates on the street that comes to the people. Of course, the intensity is very high, so it's difficult to maintain the camera, but you see a shear wave that propagates here. So how you will generate shear wave into the body? Of course, we will not detonate bombs. You can hit people. So if you don't like James Franco, it's okay for you, this GIF. You can use natural vibration. When your heart beats, it generates shear wave into the tissue. You can speak when you sing. If you place your finger on your neck, you will feel vibration. And this is shear wave that you feel. And you can use radiation force, and this is what I will explain to you now. So, 2 things to know. Shear wave propagates at only low frequency in soft tissue because the viscosity of tissue is very high. So higher than 1 kilohertz, it's very difficult to have shear waves. And secondly, shear waves propagates at some meters per second. So if you want to follow them with a resolution of about 1 millimeter, you must have 1,000 images per second in order to follow them. So you see here that the classical echography, the classical ultrasound imaging at 50 frames per second is not fast enough. So we need to build a system that is able to do 1,000 frames per second in order to see the shear waves. So here you see on the belly, the shear waves that propagate around the hand. Or when you have an ultra-fast camera, you can see this paint going out from the balloon without any problem. With a classical camera at 24 images per second, you will see nothing. You will see some blurring effect like this, but you will don't see any details. So in order to see a transient phenomena, you must be in an ultra-fast mode. So how can we do that with ultrasound? In conventional ultrasound, I showed you before, we take a bunch of elective elements, we focus the ultrasound, we listen echoes, we build a line. And we do that 128 times, as many times as we have a number of transducers. And due to that, you have 50 Hertz, 50 frames per second of imaging. Now, if you want to do it in an ultra-fast way, we will activate all the elements at the same time. Like this, you have a plane wave that propagates into the tissue. All scatters will be sent back different echoes that you will record in enough memory you need. And like this, you will need only one shot in order to get an image. So you can reach 20, 30, 40,000 images per second. It depends on the depth you want to image, but classically it's 20,000 images per second. Now, we are able to have an ultra-fast movie, but we need to generate the shear wave. And to generate the shear wave, as you see, it's not easy to use natural vibration. It's not easy to hurt people. So we thought about a smarter way, which is a radiation force. And what is radiation force? When you will take an array of transducer, you will program a focusing law in order to focus your ultrasound along one line. We do that to build an image. It's very easy. To build an image, you do that during 1 or 2 microseconds in order to listen echoes. Now, if you increase the focusing time of about 100, 200 microseconds, at the focal spot, you will generate a force, which depends on the absorption of tissue and the energy you send. And this force will push tissue. It's exactly like an ultrasound wind, something like that. If you blow on a piece of sheet, the paper will deform, and when you stop to blow, the paper will come back to its position. And you do exactly the same thing. And this will create, locally, into tissue, a vibration. And this vibration is a shear wave. So, if you image this vibration with our ultra-fast device, you see in the speckle, so in the ultrasound signal, some movement on the side, you see, that propagate on the side. And this movement are shear wave. Now, if you correlate one by one all images, you can have a displacement movie of the shear waves that you have created into the tissue. So, we have developed the technique in order to be smarter and faster. So, we have the probe. We focus at 3 different depths in order to generate 3 different spherical shear waves. As we focus almost in the same time, they will sum, the 3 shear waves will be summed in order to create a Mach cone. So you have plane shear waves that propagate into the imaging plane. And just after that, you will switch to ultra-fast imaging in order to image the propagation. And you can get this kind of movie where you see here an inclusion, which is a hard inclusion, so the speed of the shear wave increase, and you see here the shear wave front accelerate in that part in the movie. Now you can analyze this movie point by point and retrieve with a time of flight algorithm the speed of the shear wave, and the speed of the shear wave to the square gives you the shear modulus. If you multiply by 3, you have the Young's modulus in kilopascal, and you color-coded that in color. So when it's blue, it's soft. When it's hard, it's red. And it's quantified in kilopascal, so you have quantifying information for medical application. So this is really useful for physicians because it's operator-free. You don't need to generate shear wave. It's done directly by the system. It's fast enough to be real-time. When you focus, it's around 300 microseconds. When you image, it's around 50 milliseconds. So you can do that multiple times per second. So it's fast enough to have a real-time representation. It's freehand. You just need your ultrasound array, and you have a quantitative information. So with this approach at Langevin Institute 20 years ago, we did our first study at Institut Curie on different patients that had breast lesion. So sometimes it was benign, sometimes it was malignant. And we had 48 patients that we split into two groups of 24 people. And we get this information. Here you have a classical BMOD image for fibroadenoma, which are benign lesion. And you see that there is an elastography map, which is very blue, very soft. And here you have carcinoma. So this is cancer. And you have a hard tumor that you can quantify of about 200 kilopascals. And if we do a sensitivity analysis, you can separate benign and malignant patient. So based on this idea, in 2005, we have launched a startup company, which was Supersonic Imaging. It's based in Aix-en-Provence now. It's still live, and they have developed a lot of devices that I use every day in my research to do ultrasound imaging, and I will show you what we can do with the device they have developed based on this concept. So the image is here. Okay, so you see the evolution of the system along years. So this was the first prototype that we get in 2006. I started at CNRS in 2005, so just after my start. And we evolved into the Max 30, which is the common, the device that is sell right now. And the technique has been developed for, I'm not sure if the movie is working, sorry. Yes, it's working. So you see the system is fast enough if you want to scan a phantom in terms of elasticity. You go on the top of a hard inclusion and you can see it very clearly without any problem. And it has been developed for different applications with different probe at different frequencies. A microconvex probe for brain application in neurosurgery, endocavitary for cervix or prostate, or linear for muscles or many others applications. After that, for what elastography is used, the main pathology where the technique is used is for liver fibrosis staging. And we can see that if you do elastography acquisition, you can see that depending on the stage of fibrosis you have an increase of the stiffness, and it can allow you to predict what is the grade of the patient and to avoid you biopsy. So thanks to the development of this device with the company, we get a beautiful system in order to go back to physics and develop more things. And until now, I present you elastography and the other techniques. And the main hypothesis made were that we are simple soft solid. And when I say that, I say we are isotropic. We are the same in all directions of space. We are purely elastic. We are linear, and we are passive. It means that the shear modulus is defined by these four hypotheses. But of course, as you know, the human body is much more complex. And the first simple thing you can show to explain that is a muscle as an example. If you take a muscle, you have a lot of fiber aligned in the same direction. And in the perpendicular plane, the fiber are randomly spaced. So it defines in crystallography a transverse isotropic medium. So you see directly, just by the first organ that you have at the surface, the muscle, that we are not isotropic, but we are anisotropic. So if you consider the body much more complex, now you can approach different mechanical parameters by looking at all these properties, and I will explain to you how it's possible to do it. So, as I said, we are also anisotropic with the example of the muscle. We are viscoelastic. We are able to absorb energy coming from the outside. We are nonlinear. Our stiffness changes when you apply a stress on it. And we are also active. When you contract your muscle becomes hard. You can change your stiffness in real time. So, all the parameters, how can we estimate them? First, for the anisotropy, I will take a simple fusiform muscle, like the biceps, and if I place the probe aligned with the axis of the biceps, when I will do elastography, I will push with radiation force perpendicular to the fibers. So the shear wave will propagate along the fibers. The shear wave propagates always in the axis perpendicular to the axis of the radiation force. When I do that, I can see that if I increase the loading on the muscle, I will have a shear wave speed estimation that will increase with the contraction. Of course, you contract your muscle, it's become harder, so you have an increase of the speed. And now, if I want to have the anisotropy, I will do the same thing, but I will rotate by 90 degrees the probe. And in that case, I will push perpendicular to the fiber, and I will have a propagation of shear wave also perpendicular to the fiber. So I will have another estimation of another shear modulus. And you see here that the speed of the shear wave is smaller than parallel to the fiber, and it increases also a little bit with the contraction. So like this, we are able to quantify an anisotropic ratio into the tissue. And it is currently used by my colleagues in Nantes to characterize some myopathies, because when you have some myopathies, the fibers are replaced by fat infiltration or fibrosis or other things like that. And this ratio changes a lot. So it's a new information that helps them to characterize different pathologies. The second parameter is that we are also viscoelastic. So we are defined in terms of mechanics by an elasticity and a viscosity. And if I take a Voigt model, which is a dashpot in parallel of a spring, I can write the expression of the shear wave speed as a function of its frequency, like this, where mu is the stiffness, the elasticity, eta is the viscosity, and omega is the frequency. If I generate a shear wave, my probe is here. I push along that line. This is just a one snapshot at one time. I see the shear wave here, and the shear wave will propagate along that line. If I take a mean over the whole depth, I will represent that in that way. So this is, once again, shear displacement. So this is the width, the same as here. And I pushed here at this width. So here at width 30, I see two shear waves that propagate, one on the left, one on the right. Here, one on the left, one on the right, as a function of time. So this is the shear waves that propagate as a function of time. This is a 1D representation. And if I take the Fourier transform of that, I can, like this, get the spectrum of the shear waves that propagate. If I calculate the phase delay for each frequency, I can get, like this, the velocity in black. And if I fit this this dispersion curve with this equation, I can go back to viscosity. So we can also complicate the thing, and we can have an anisotropic viscosity. So we can do the experiment when we are parallel to the fiber or perpendicular to the fibers. You see that when you are parallel and you increase your load, you increase your contraction, you have a flat dispersion curve. It means that the viscosity is very low. but when you contract, you will increase your the mean value of the shear dispersion curve, and the curve is always flat, so it means that the viscosity don't change so much. And when you are perpendicular, at low frequency you have the same value of shear wave speed, but you see that the slope increases a lot, so it means that the stiffness, the elasticity doesn't change so much perpendicular to the fibers, but the viscosity increases. So when you contract your muscle, you will increase your elasticity along the fibers, and you will increase your viscosity perpendicular to the fibers. Third parameter, we are also nonlinear. So how can we explain that? Nonlinearity is involved when you will apply a stress on your soft tissue. When you have an isotropic material, forget about anisotropy. An isotropic material, the shear wave speed is linked directly to the shear modulus. You have in each direction of space one shear wave that propagates. Now, if you apply an uniaxial stress, you will have 3 shear waves that propagate into the tissue. If the polarization of the shear wave is perpendicular to the stress axis with the propagation also perpendicular to the stress axis, you will have this equation. If I turn my probe and I have now a propagation along the stress axis, I have got this one. And in that case, the propagation is perpendicular to the stress axis. I got this one. And when I use the acousto-elasticity theory, this is a theory that explains the nonlinearity in tissue, when you apply a stress, you will have this parameter that appear, which is the nonlinear terms. And you see that if you have no stress, sigma is equal to 0, this term vanish, this term vanish, this term vanish, you retrieve V equal V square equal mu. You are in the case of isotropic medium. So how can we retrieve this nonlinear parameter that explain how the speed of shear wave change when you apply a stress on it? You will do an experiment. So we take this configuration, we construct a setup in order to have this configuration. So we place a transducer array on the bottom. Here you have a phantom, a gel with an inclusion inside. You generate shear wave that propagates horizontally, and the radiation source is vertical. And you will apply a stress here with a plate at the top. Like this, you will change the stress you apply. You acquire, before compression, a shear modulus map. So you have a soft inclusion into the material. And you apply a small stress in order to get a new map. If you multiply by 3, you get the Young's modulus when you have no stress. So here we acquired V for one step of compression, and mu, which was mu at 0 step before compression. As I get an image before and after compression, I can do some static elastography as I showed you before. We can calculate the strain map, and here I have the strain map. And if I apply the Hooke's law tells me that the Young's modulus times the strain gives me the stress. So in that case, I can have a stress map, and I can retrieve sigma here. So the only parameter I miss is the A parameter. I can like this define the nonlinearity. So I will do the experiment in a nonlinear phantom. So how I built a nonlinear phantom, I take simple materials like gelatin gels, and I place some soft tissue part inside. So here it's a piece of liver that embedded into agar gelatin phantom. I mix the agar gelatin in order to get the same stiffness as the liver. So if I do a shear modulus maps, it's almost blue everywhere. So the linear parameter is quite the same for each different part of the phantom. And now I will apply a stress on it. So I acquire a shear modulus map, and you will see here on the plot 2 different points. For the red point in the gel, the blue point in the liver. And you see that when you apply a stress, you have a change in the shear modulus map, and you see an increase of the stiffness into the liver and also into the gelatin. And you see that the last shear modulus map is quite different. And this map is quite different due to the nonlinearity of the material. If I fit this point, I get the A value. I do that for all the points of the image. And like this, I can get this kind of images with a new contrast on nonlinearity, which is coded also in kilopascal. It can be negative, it's normal. And you have a new contrast that helps you to better maybe define pathologies. So with this idea, we went back to the clinics and we tested on different volunteers. In the breast, you apply some compression, 6 pressure steps. It's about between 5 millimeter and 1 centimeter compression, so it's not big enough. So you can get the shear modulus map, and you can get, after compression, the nonlinear map. And if we do that on a patient with a cancer, you have a cancer here inside. You see here on the B-mode, this is this small area. If you do the shear modulus, sometimes the shear modulus doesn't change so much. So here you have a small increase, but it's not clear, really not clear. If we apply our compression step, you see that the last one is quite different. And if we calculate the nonlinearity, we get a beautiful contrast on the cancer directly into the on the device. So it can help you when the shear modulus is not precise enough to have a new information to better characterize your pathology. And the last properties I will show you with elastography is that we are an active solid, so we are able to change our stiffness in real time. So if you do acquisition on the calf as an example, if you take up your feet or take it down, you will have different contraction of the calf on the upper part or on the lower part, depending on the where you place your feet. This is a voluntary contraction. You can also follow some involuntary contraction because the system is real fast. So here it's an uterus that is contracting before delivery. So you can see change in the contraction. You can have some information. And I will switch that, it's okay. Another example of application of elastography when you want to follow in real time a change of stiffness is here an example in an application on the diaphragm. When the diaphragm contracts, it will generate change of pressure that allows you to breathe. And it is really important to know how the diaphragm is contracting to help patients, especially in the ICU, in the intensive care unit, because the health of their diaphragm is very important to know if you can unplug them from mechanical ventilators. So we did some measurements on volunteers, and we showed that we were able to quantify stiffness as a function of time. And we related that with internal pressure estimated with balloons into the catheter, into the esophagus, and into the stomach. And this is what is classically placed in the patient in the ICU. And we showed here by this result that here in green, you have the change of pressure measured by a balloon. And in red, you have the change of stiffness estimated by echography. And currently, we are replacing these balloons in the ICU by a simple echographic application that helps us to have a less invasive technique to help people to be to be ill at the hospital. So I showed you many things on ultrasound, and I showed you how we can do ultra-fast imaging with ultrasound. And we can do some shear wave elastography. We can do some ultra-fast Doppler imaging, I showed you. I didn't speak about natural shear wave, and contrast, I will not speak about that. But we can also use ultra-fast ultrasound to improve a new field of, to have a new tool in neuroscience by doing functional ultrasound imaging of brain activity by using ultra-fast Doppler, ultra-fast ultrasound, and I will explain that to you now. So by using ultra-fast imaging, and it comes back to the question about coronaries, we can improve Doppler imaging. When we do Doppler, I showed you that we will focus ultrasound on one line. We will acquire a certain number of samples in order to reconstruct the Doppler signals. And then we will switch to the line on the side in order to have another point in our image. And we do that, and we do that, and we do that in order to build the right image. We have the information about the blue flow, the red flow. And if we want to have a very high information about the change of velocity in one point, we will focus our ultrasound along one line in order to have a huge number of samples to get a beautiful sampling of the change of speed of the blood into vessels, but it will be only in one position. By using ultra-fast ultrasound, you can couple both because you will send ultrasound over the whole array. So on each point of space with the same sampling frequency. So like this, you have a combination of the way to build an image, a color Doppler image, and the way to have a pulse Doppler image that quantifies the speed in one point. With that, you can have beautiful images with a strong sensitivity. Here it's an example through the fontanelle in babies, and you see in the cortex, in the thalamus. And when you do that, you can have a lot of information. You have acquired all the image. You did a summation in order to have this power Doppler image. And after that, you get also the spectral information for the whole point of the image. So if you have a cursor that you move into the vessels, you see the change in the spectrum of the blood flow, which correspond to the change of the speed of the ultrasound of the red blood cells into the vessels you follow. When it's flat, the speed is very low, so it's mainly veins. When you have a high spectrum, there is a pulsatile flow. This is arteries. If you analyze that, you can define what we call a resistivity index. So when you are in a vein, the spectrum is very flat. When you are in an arteries, you have a big spectrum. If you take the mean value and you take the mean value of the velocity and the max value of the velocity, you can calculate this resistivity index, which was defined by Leon Pourcelot in the 70s. And you can, like this, with the ultrafast information, get this information for each point of the image, and like this build a resistivity map which gives you what is vein, what is arteries. And my colleague Charles Guimenet published a beautiful science paper, and he gets the covers with a beautiful image on babies 10 years ago, almost 10 years ago now, yes. So when you do that, you give the possibility to ultrasound to enter in neuroscience, because with these improvements of sensibility, you can get off the lack you get with ultrasound compared to the other techniques. Now, with that, you are able to see small vessels into the brain. And if you are able to see small vessels, you can look at cerebral blood volume variation, which is coupled to the neurovascular coupling. And if you look at this change of volume, you can know where neurons are activated thanks to that. So, and you can do that only because you are ultra fast. If you do a classical ultrasound image on a rat brain, here as an example, so this is without the skull because the bone blocks the ultrasound, so we remove the skull and we acquire ultrasound. If you use classical focusing law, even if you increase the number of focusing in order to increase your SNR, signal to noise ratio, the quality improve a little bit, but not so much. But if you do ultra-fast imaging with more than 1,000 images per second, compounded in order to have this kind of image, you see that you can improve a lot the sensibility of the technique and see more vessels and more capillaries. You can do that on the whole brain by just moving the probe, and you have a very good resolution with about 100 micrometer resolution. You can calculate the red flow, the blue flow, to see what is coming up to down. And you can also reconstruct the whole vascularization of brain because you have real-time acquisition. You just need to move your probe, and for each position, you reconstruct the vascularization map. And if you concatenate the whole acquisition in all directions of space, you can, like this, if it works, yes it works, reconstruct the full vasculature of here a rat brain with a very high resolution of 100 micrometer. So you have the cortex on the upper part and the deep vessels, and after that you can play to go inside, to see inside. There is a little ischemia here on the top due to some surgery problems. But when you get that, you have beautiful information on the anatomy of the brain. You can differentiate different structures, hippocampus, circle, Willis circle, many things like that. And are you fast enough? As you can acquire a lot of information, you can see also in real time and see the beating during the heart cycle of the vascularization into the brain. If you are able to see it in real time, now you can look maybe at classical mechanical activation into the brain and see if you are able to see change of cerebral blood volume due to some external things. So the classical model is to use the whiskers, and when you vibrate the whiskers, it will be a part of neurons that are very well known that will be activated due to the vibration. So what we will do is we will place the probe at the top of the brain, just on the neurons that you want to see. We use the Paxinos atlas in order to define the position of the neurons. And when you will vibrate the whiskers, the neurons will activate, so they will need more oxygen to work, so they will need more blood flow, and so the blood flow will increase locally due to the activation. And here, it's a movie. You have one image per second, and when you activate the whiskers, you see, if you calculate correlation between all images, you see an increase of the red blood flow locally on the side where the neurons are activated, and you see also the relay into the thalamus here during activation. If you correlate your cerebral blood flow signal on one point with the stimuli that you have involved, you can like this build some correlation map and have some map of activated pixels. You plot that on the Doppler image that you have acquired before, and like this you can see where the neurons are activated. This is exactly like with a functional MRI. When you do bolt imaging, you place on your anatomical image your bolt signal. This is the same way. What is the precision of that? So if we use different rows of whiskers, we will activate more or less neurons. So if we activate row C, D, E, we get this port. Less row, C and D, this port. Row D, only this port. And it works with also one whiskers. So, but for that you need to acquire a long time because you need a lot of data to have enough sensitivity, but it's feasible. You can see the activation of one bench of neurons for one whisker. This is when you generate the when you apply the activation by yourself, but you can also follow some pathological effect in the brain. And especially, you can also see how the vascularization changed due to some pathologies. And here, the epilepsy. So this is a typical experiment where they inject 4-AP drugs into the brain that will generate an epilepsy. And you will film the Doppler image of the brain during 1.5 hours, and here I will show you one image every second, and you will see the change of blood flow during the injection. So here you have the time that goes, and you see that the drugs has been injected here, so you see some movement of the red blood flow that goes to the thalamus. So when it's blue, you have less blood that goes into the vessels. When it's yellow, you have an increase of the blood flow, and you see that will goes to the other part at later. I don't remember. No, we don't see it. But you can follow some pathological things into the brain by this technique. We can also correlate that to electrical activity. So for that, we have placed some electrodes in the brain. We have acquired ultrasound, and we saw that there is a strong correlation between the change of blood flow with electrical activity of neurons. And now we always did that with an anesthetized rat, but how to go further? We need to when you do this experiment, you need to make the rat sleep. So you need to use isoflurane or other drugs. And when you do that, you will modify the chemics of the brain. And if you want to study the brain, it's better to have no chemics. So compared to fMRI, we don't need, with ultrasound, to anesthetize the rat, to place it in a tube. You can follow its brain activity in real time with this device fixed on the head. So this was the first prototype. I will show you the probe after that. They are smaller, like the mon ongle. Voilà, mon ongle. Voilà. So this side, 1 centimeter square almost. And like this, you can follow the brain activation during the real life of the animal that has a pathology or that does things different in the cage. On the side, you have a small motor here in order to move the probe from top to bottom, in order to have different plane in the brain. And here, so this is the second generation of the probe, which is much smaller. And here I will show you an experiment with a Gaertz rodent model, which is a rat that has natural epilepsy. So there is a video recording of the rats. suddenly he will have convulsions, a seizure due to the pathology. We record the Doppler. We record the correlation between all the Doppler in order to see the activation, and we record also the EEG recording. And every point here, you will have an ultrasound image every 3 seconds during the experiment. So, if the movie works, it should work. No, tac. No. Okay, it starts. The rats begin its seizure. You see it on the EEG. You see here the hippocampus that lost their blood flow. After, during the epilepsy, there is a loss of cerebral blood flow everywhere in the brain. And just before the end, you will see the hippocampus will perfuse again a lot. Then he lost everything. And it will come back to normal just after that. Okay. So this is a new way to see how the brain behave during this kind of seizure or this kind of pathology. We had a beautiful publication about that of Lima Nassieu, which is at Biomass Laboratory now. So it was the experiment she developed. Here it's a study of the rat behavior when it's in a labyrinth to go to take water on both sides, and how the brain change due to this activity. So this is a kind of surgery that she applied with here the connector for the electrodes that are inside. The skull is removed and replaced by TPX. It's a kind of plexiglass, so you can keep your animal during months without any problem, and you can use it to do multiple experiments. The probe is fixed on the top with this small screw, and you can follow its life for different applications. Here it was one which has seizures, and we record the EEG, we record the B mode, and we study different places in the brain during this pathology. And now the technique is easier. I showed you with a rat. With a rat, we need to remove the skull. Now, if you use a mouse, you just need to remove les poils, sorry, and you can do the experiment with the full skull, because the skull is thinner, and like this ultrasound has no problem to go through it. So the mouse is anesthetized. We remove the plastic that block the air to grow. There is a small metallic plate that is fixed on the head, glue on the head in order to fix the array. So he placed here some gel. We fix the probe with just some magnet, small magnet. You see that the size of the probe has evolved a lot. It's very small, very light. You clip it on the head. Like this, the animal can live its life, move into a labyrinth, do what you want to do, or what you want the animal to do. And after that, you acquire on the device acquisition of the mouse brain during some stimulation or whatever you want. So you have a very new tool to do some neuroscience easily with ultrasound, with respect of all the animals we use. So it just will replace some cast in order to and like this you can do some chronic experiment and do many things on the animal. You can do that in 3D if you move if you have a more complex device and you move your probe, you can reconstruct the whole brain. So you saw that it was possible to do functional imaging on animals, but the idea is always to go on humans. So toward clinics, how can we go to clinics? The problem is we cannot remove the skull, as for animals, of course. So how it's done for now, there is two ways where you have no skull in humans: babies, fontanelle, and neurosurgery. If you want to do fMRI, I'm sorry for the MRI people here, I'm sorry. But for the babies, you need to have a magnetic couveuse, comment on dit, je sais plus, mais a magnetic things if you want to study the brain on newborns. And in neurosurgery, you can do perooperative imaging, but it's quite complex. Because the field is very complicated. It can be done, but it's complex. So in these two small areas, ultrasound have their place. No school for the babies, so you can use ultrasound. I showed you some images before. And in neurosurgery, you open the school naturally because you want to remove things, so it's easy to do it. So across the fontanelle, you can have this kind of BMOD image without any problem. You can do some ultra-fast Doppler imaging in order to have this beautiful image of the thalamus and see many things. And in neurosurgery, you can do it also because you have removed the skull. So if you use classical Doppler imaging, you will have this kind of information. If you use ultra-fast Doppler imaging, you see that you have more details, more information, you can see more vessels into the brain. So what we have did is we went to the operating theater. I'm here with the ultrasound, the Explorer, the ultrasound device. We have modified a little bit the interface in order to acquire Doppler imaging. And here you have a patient that came to remove a tumor. And if you want to remove the tumor, you must know where are the functional zones in order to improve its quality of life after surgery. And to do that, the classical way for the neurosurgeon is to send some electrical pulse at the surface of the brain during the patient is awake, and to ask to the patient what he feels during this electrical state. He can do that at the surface of the brain, but not in depth. So here we come with the ultrasound in order to see in depth where the activation are made, in order to help the neurosurgeon to resect the tumor without touching the functional zones. So here you have a metal arm with a probe placed on the head of the patient. This is an example. So the neurosurgeon is here. He has an electrical device and he will send some electrical pulse at the surface of the brain. You have an orthophonist that speaks with the patient, which is awake during the experiment, during the surgery, sorry. Not an experiment, a surgery. Just after, this is a surgery picture, so don't worry. Okay, it's normal. You will see some blood. So during the experiment, before the surgery, he gets fMRI acquisition to define the functional zone. during the surgery, it generates electrical pulse in order to map where are the functional points around the tumor you want to remove. When it's done, we will place the probe at the surface of the map to see something into the brain where the neurosurgeon is interested to look at. So here, typically, it's a position where you see the mouth movement and some feeling into the lips. We ask the patient to be at rest, to move the mass, to be at rest, to move the mass, to be at rest, to move the mass, to define our stimuli. And during it does that, we acquire a movie of Doppler imaging. And here you see not so much you don't see any change in the Doppler movie, but if you correlate this Doppler movie with the stimuli I showed you, you can, like this, define some activation area corresponding to this movement. And like this, the physician can remove the tumor, knowing where are the functional zones and trying to not destroy them or to not resect them in order to improve the quality of life of the patient after that. A small movie to sum up that. It will start, yes, it starts. So we have the brain, we have the zones that are defined by electrostimulation. We place the probe where we want to see, where we want to have some information to plan the resection. So during rest, there is nothing. During motion, you see that this part activates a lot. So the neurons corresponding to the movement are around this area and at rest. And like this, you can define in depth where are the functional zones. And for just in time, I would like to thank you for your attention. And I would like also to thank the whole team and all the students and technicians that work with us, because without them, we can do nothing. So it's important to think about them. And of course, we have postdoctoral position open. Thank you.